Sorry. So there were two things in particular that we were looking at today is obviously understanding the provision of healthcare in general, which is the learning outcome 3 in this particular unit, international healthcare policy. And to look at covering that topic, what I've done so far is I've sent you an email on Yahoo as well, which has a copy of the presentation that we will go through. And it also has two handouts in particular. One, if you recall, we had kind of said that we will study the Danish healthcare system. So what I've done is I've sent you a snapshot of the Danish healthcare system in particular. This is something that I've got, from the Commonwealth, fund, and they kind of do a compilation of this particular study once a year, which has the profiles of the healthcare system, for different countries. So in particular, sent you that one handout for the Danish healthcare system. Yes. And the other, what I've done is I've sent you a handout which basically has 3 or 4 tables. And these tables basically look at comparing the healthcare system and the coverage in about 15 different Commonwealth countries. So it is a good snapshot in terms of a tabular, table snapshot, which basically neatly summarizes the healthcare system, public and private aspect of how it works within these countries, and what are the benefits, and obviously how's the funding done, what percentage of population is covered using that particular system that they have in their country, and last but not the least, how is the performance monitored, and obviously how do they look at basic things like basic care and secondary care, mental health care services, and also long-term illness and services related to that. So it's a good snapshot which kind of will help you maybe get an overview of how the healthcare system works in different Commonwealth countries.
Super, that's excellent. I heard on the news this week that they were on the breakfast TV that some girls had started a charity in Devon because their mental health patients had to go to Manchester, which appalled me.
Yeah. Oh my God. Yeah. I think, to the best of my knowledge, there are 2 services in general in Lancashire, in Greater Manchester in particular, which basically are funded, and I think these are funded through the NHS in terms of public services, both for mental health care and also for substance misuse. So one of them is HSC, which is a trust, and I think it's been spun off as a public-private partnership somewhere based in Bolton. And there is one which is obviously in Greater Manchester, which is still with the NHS, and I guess a lot of patients get referred. In terms of this being a kind of a large setup in this region. So I think it could be because that there are free beds or free in the sense provision is available for patients to come in and obviously look at being accommodated here, something like that. But from Devon, one corner of the country, to who's looking at Northwest, it is appalling in the sense that it is quite far off. If it's within 10, 12, 15 miles, still tolerable, but if it's going to be in excess of 200 miles, then it is not acceptable.
Yeah.
Not acceptable. I think what I would let's put it this way. I think keeping in mind that we are coming out of declare, so the Brexit I think will also create a bit of new set of challenges for the NHS, and there is a lot of funding which was in some way, a lot of people are talking about that there's going to be a U-turn because some parts of funding within the research side of NHS is already committed, and it's vice versa from the European Union. But because of some bit of direct funding which is coming from the European Union towards the NHS, because there are there are citizens or people of other nationalities living in the UK might get affected. And similarly, when we had the provision of having the the European card, wherein we could avail some of the services while you're on holiday or on work or, short vacations within Europe. Those kind of things, I think, will put some sort of additional pressure with maybe funding getting squeezed. And when we look at chunks between the 4 different countries that we look at, I think 53 to 55 million within England, NHS has a lot of, the largest part of funding. I think about 76% of that, from a point of view of the national budget, actually comes to England. But that is also not because when you look at the population versus the provisions, I think a couple of months back there were discussions in the Parliament which was saying that NHS is drastically falling short of funding, and they'll have to look at cuts and things like that. There's a deficit of about 20 billion pounds, which is required just to plug in the gap in terms of what is required and what currently is available from the various funds which kind of fund this particular whole operation of NHS within England. So I did a bit of digging just to understand the structure, and I think 1 or 2 things which I will forward on. One of them is this briefing paper, and the other is a bit of information which is available on the NHS England website, which basically explains the structure of NHS in England. And I think this is pretty much recently released on the website, because it talks that it was, and that is pretty much the same dates. I think it talks about the last review was done on 13th of April 2016, and this paper I think was released as you can see that April 2016, but the paper was actually published on 10th of March 2016. So the information on both the places pretty much as of now quite current. But I think the overarching structure that we were looking at was that, obviously the Secretary of State has the overall responsibility, and the Department of Health in particular provides the strategic leadership of both public health and social and mental care and other services under the NHS. And underneath that, we have the CCGs, which were the clinical commissioning groups, which work very closely and are monitored through the National Institute of Health and Care Excellence, NICE, that we covered in the first session, and the CQC, the Quality Care Care Quality Commission, which basically looks after monitoring the functioning of these clinical commissioning groups and the various PCT trusts, which were kind of merged and dissolved, and this overall structure came about. So this chart, I think, is pretty much an accurate, if I just magnify this slightly, pretty much an accurate description of how the NHS is, this was pre and this is post. So this bit of structure is what we are looking at. It's quite current at this moment in terms of how the NHS actually operates within England and Wales, and in some shape or form within the other 3 large countries like Wales, Northern Ireland and Scotland. The other bit, which was news to me as well, because I did a bit of digging about myself, is that there was some creation of health and well-being boards, which were created by, in general, by the local authorities, which kind of act as a forum, and obviously are responsible, wherein they are inlets to basically taking on, the feedback from patients, clients, councils, and obviously, the GP surgeries, in order to better the provision of healthcare in general for a particular area. And along with that, we had something called, some safeguarding regulation, which was introduced in order to ensure that continuous improvements keep taking place, where, the gap areas are identified after inspections by the CQC in certain, hospitals and trusts. And these were 2 other separate bodies which are not directly under the control of NHS, but they are independent bodies which sit outside and, kind of provide inputs in terms of feedback, quality improvements, suggestions, and, testing of, say, for example, IT system, the availability of patient records, the electronic form of the patient records and other things which are then centrally monitored and provided across to hospitals, GP surgeries, and various other services which kind of form the whole provision of the NHS or National Healthcare System. Now, I think in terms of this quite pertinent is because if I look at studying the Learning Outcome 3 from the context of what we are looking at today, there is a bit of coverage on the structure of NHS that we are going to look at. In particular, if you see the publish, and in this presentation, what we are looking at basically covering, will be broadly, just very broadly, we'll be looking at covering 3 or 4 things in particular within this. And one of that will be that we are looking at, understanding what is the role of the government in particular, when we look at the healthcare within the remit of England and Wales, essentially. Say England, not even Wales. We will also understand who is covered and what kind of services are covered in some of the slides that I go through. We will also look at, in terms of the coverage, then we will put some emphasis on the services, how these services are provided. We'll look at maybe the cost sharing which happens between and how it is funded in terms of the budgets for NHS. We'll look at a bit of a net in terms of people like prescription, when we pay for prescription, or when we look at patients who require large number of repeat prescriptions, or they require prolonged healthcare in terms of because of disabilities or other things like, and how is that safety net kind of work, that concept of the safety net, how it works within the NHS. We will also look at, when we look at studying the provisioning, is we'll understand how this system is financed in general. So where does the funding for NHS actually come from? How much of it is of the UK GDP, and what parts of it is financed through the general taxation, and what percentage or portion of that actually comes from the national insurance contributions. We will very briefly look at how the delivery is organized and financed. And the reason why we will look at is in order to get an understanding, which is with regards to, if I just pull out, the spec sheet, is what we are looking at is there is a bit that we need to understand is how is the healthcare organized and delivered in the national context. So what we need to be able to understand is how many GP surgeries, how many GPs, and how many hospitals, consultants all working together under this remit of the National Healthcare Service to see how it is organized and then delivered to the general public. And last but not the least, I think towards the end, what we will look at is just passing mentions of things like within this infrastructure, we look at hospitals, how is the mental care, mental health care organized, how are the needs for long-term care and social support, which is required for patients, is considered and is delivered through the NHS. And last but not the least, looking at the structure, which I put, a chart, which is the organizational chart of NHS, and how this is then shaping up in terms of with the changes which are happening over the years, over the decades, in the NHS, and how these costs are being contained, and the reforms being brought in are going to introduce, they are going to be introduced, and also looking at some of the innovations which are being brought in to try and save costs, cut budgets, but at the same point in time make costs and the cuttings in terms of reduction of budget happening in places wherein it is non-essential services, but they're being reprioritized and rerouted to look at patient care and obviously clinical need services, so that the overall structure is well funded as per the new, obviously the changes coming in from the Department of Health and the Health Secretary. But in terms of how they pan out, I think it is too early to assess, but the full impact of the reforms and the changes that they're trying to bring in will obviously become clear in the years to come. So this is what we are going to look at in terms of the remit of our discussions today. So looking at understanding healthcare provisioning, understand the practice, the organization involved, and how this structure overall works, to be able to give, how this overall structure essentially gets funding, and what is the private-public partnership, and how it goes forward in terms of delivering healthcare to mass general public in general.
It's LO3 going.
Is that okay? Right. Now, yeah, the presentation that I have is quite worded in terms of these slides.
The slides.
And
Because I just need the tree because I can't see from my window. Please.
ask me.
No, I'm thinking.
So what I'm going to do is, obviously, the idea was to try and squeeze in as much information as possible from a point of view of giving you insight into the things that we are going to study. So some of these things on the slide would be quite self-explanatory, and also you might be aware of it because of your profession and obviously background. So in general, I think I'm just going to go through some of the slides, and if you have any questions, just feel free to ask. And what we'll do is we'll discuss, and I'll try and see if I can provide you additional information that I have on that side.
Okay, that's fine.
Good stuff. So starting with, what is the role of our government? Essentially, when we understand healthcare provisioning, as you know that within the UK, when we look at the NHS, the healthcare services actually provided free of cost, to everyone. So there is no barrier in terms of who can access, as long as they are covered within the remits of being either citizens or EU citizens. The healthcare is pretty much provided to them. Its provision to them is pretty much de facto guaranteed. Now, the idea of looking at what is the role of the government is basically they have the clear responsibility to set the policy and obviously define the legislation under which the Department of Health actually provisions for these services free of charge, and makes them available to the mass public or general public. Now, there are a few bodies which have got formed over the years within the NHS structure, and the NHS constitution that we talked about, basically was created to make sure that there is no discrimination in terms of providing these services within the NHS to one and all. And what we also see is that there was a commissioning of the NHS board, which was renamed as NHS England, which was done after the NHS Health and Social Care Act, which was introduced in 2012, also looks at now, managing the NHS budget specifically for England and in England, essentially, not England and Wales, because I've got used to England and Wales. That's the reason I say it, but it's predominantly England that I look at right now. Now, in terms of some figures and facts, obviously, what is covered and who is covered, I think, from the last count that I looked at, which is data published on the NHS website, there are some 211 local clinical commissioning groups, CCGs as we call them. And these 211 commissioning groups essentially, set out the objectives and are responsible for carrying out the objectives which are set up by the Secretary of State in order to ensure that, the routine services of NHS are actually carried out and made available to the mass public. Now, in terms of coverage, as you can see, the coverage is universal. Now, that is defined as anybody who is ordinarily resident in England is automatically entitled to get healthcare, and that is largely free of charge at the point of use. But some non-residents, which are either EU citizens or members of EU, are also entitled to get this care absolutely free of cost. There are some changes, as you know, which have been introduced in the last, there have been discussions about these changes in the last few months and years, is to exclude data about students, international students coming to the UK for studies. And I think last year, sometime, I think last year in April, NHS England actually introduced something called a medical surcharge, which is what the international students who are coming to the UK to study from outside the EU are required to pay. And then in those cases, people coming into England in specific or UK on tourism purposes or for study purposes, there the funding of the services, if they are to fall ill or they need services from the NHS, is actually paid for. And this then became something which was put together as an act, I think last year in April, approved by the Parliament, and the students are now supposed to pay for these services when they are actually on a tier 4 or study visa or a work visa. But in general, the coverage.
Not the work visa, a T what for? A T?
Tier 4.
TF?
No, tier 4.
Tier 4.
Yeah, basically, I think in the immigration system, if you look in general, in general, if you look at the forms of visa which people can get, there is a tiered system in the immigration, and tier 4 in particular is a category of visa wherein students who are coming in from outside the EU to study in the UK are now required to pay NHS surcharge. That means the NHS services to students who are studying here for 1, 2, 3 years or whatever time period is not considered absolutely free. So there is a surcharge which the students end up paying to receive the NHS services while they are here on that particular visa, and that visa is particularly called tier 4. So this legislation was introduced last year, and I think when I say the coverage is universal, I want to be factually correct, is that this is universal for people who are residents in the UK, have are born and bred here or have nationality, the residents of European Union, and anybody apart from that which is coming in either for travel, tourism, study purposes, work purposes. Then in those cases, the provision of healthcare under the visa system is not considered absolutely free. So they have to pay a NHS surcharge, which then makes available these basic services for the time that they are here in the country.
So a tier 4 may face surcharges, is that correct?
That is correct. So these surcharges are in place from last year, June. This was introduced in April last year, and I think it became a legislation. So anybody who's now applying for a visa to come and study in the UK from outside the EU has to pay an NHS surcharge along with the application fees when they make an application to come to the UK.
Yep.
Okay. Now looking at some of the other things with regards to when we talk about coverage, what we are saying is, okay, the coverage from a point of view of services given by the NHS, and other services within the NHS is free. But looking at who are covered under these services is what we look at is the way in which now it is clearly defined that the NHS provides different types of services. And these different types of services, are basically, in practice, services which are preventive services, which include screening, immunization, and vaccination programs that we look at predominantly for, the young children or the newborn, or people who are 60 or 65 will get. There are inpatient and outpatient hospital care, which tends to happen, and there are physician services, inpatient again, and outpatient drug services, and then clinically desired services which are required, which are predominantly given through the hospitals in general within England. So what we look at is here, the idea is to understand what type of services does the NHS provide. And this particular slide kind of covers and at least names all the types of services which NHS is able to provide through various outposts that it has, and also with the combination of GP surgeries, hospitals, community-based services, and other mental and social care trusts which are established under the NHS. Now, some of these services that we look at are on a varying basis, and some of these services, are predominantly, also funded through, the various funds which the government then makes available to NHS for running these services. But there are limited cost-sharing arrangements. So, for example, when you look at outpatient prescriptions, for drugs, things like that. There is a surcharge that we pay. I think in England, is it £8? Is it 7.20? I think it's 7.20 till, isn't it, for the prescription charge?
I definitely remember it being between £7 and £8 recently.
Yeah, I think I've tried to look at it, and I've probably put this across as 8.05, but last I recall, when I went to the pharmacy, I think it was about 7.20. So there are some charges which are obviously on the cost sharing basis. I think prescription charges, there are no prescription charges in Scotland and Wales, I think. I'm not too sure about Northern Ireland, but I think in England definitely it's between 7.20 and £8, for people who are looking at getting prescriptions or drugs from pharmacies over the age of 16. So for children up to the age of 16, I think it's totally free, and for adults beyond the age of 60, they are absolutely free. There are no charges, but anywhere in between, if you are there, I think these charges are co-op payments which predominantly go towards the prescription-based drugs. Now, dentistry services, as I understand, are not free, and they are paid for. And there's a maximum provision of about £219 per treatment, which is covered under the NHS. Again, there are certain age categories in which this particular service is absolutely free. For kids under the age of 16, I think the services are totally paid for and funded by the NHS. And similarly for senior citizens or people over the age of 60, it's absolutely free. But again, anyone falling between the age limit of over 16 to under 60 will have to pay for some of these services, and to a certain extent, some of the coverage is there, but in special cases or in certain categories. But that coverage in terms of payments is a maximum of to £220 odd, in case of treatments. So, looking at the safety net, which I was coming to next, is with regards to. So this particular data, what I've done is, just to give you a background, this data I have taken out from OECD, and they do a survey every year to try and collect some part of this data in terms of what percentage of population looks at availing these services, what percentage of that is funded through the NHS under special circumstances like which will fall under the safety net could be things like people, say for example, ladies who are pregnant when they're expecting, people on low income group, people on benefits, children between the age group of up to 16, and senior citizens, so or people with long-term conditions or disabilities will actually be also covered under this particular survey. But these figures are quite accurate because based on the survey and data collected from the OECD, and they kind of clearly state that in 2014-15, this particular expenditure, was about 9% of the NHS budget, which went across towards the towards co-op sharing or cost sharing for arrangements to cover the prescription drugs, in general for the population in England. So. And then the largest proportion of out-of-pocket expenses, which was 53%, was actually on medical appliances, equipments, and this was followed by 30% on pharmaceuticals, which is a data and figure collected from the Office of National Statistics. So it kind of gives us a bit of a breakdown in terms of where the cost sharing happens, how is the budget within the NHS spent, and there are three large categories on which the budget is spent. So 9% of that is going into, the out-of-pocket expenditure, co-op sharing arrangements. 53% of that is predominantly towards medical appliances and equipment, and 30% of that is going towards drugs, or predominantly with contracts with pharmaceutical companies to be able to prescribe, provide prescribed drugs or prescription-based drugs to patients and hospitals, covering wide range of target group within England. If that makes sense.
Yeah.
Okay. I'll send this to you. There are some handouts which I've created. I'll send this to you just from a point of view of statistical data, so that this was last compiled in 2014-15, and that's what I have, which I'm actually using and quoting in this presentation as well. Now, coming to the safety net, I think safety net is, there are times in which, as I understand as a layman, there are some services which are absolutely free. And these services, irrespective of where you are, where you come from, or things like that, they are free. And those are categories because of the, age in particular. So the health services, both dentistry as well as health, when it comes to NHS, is absolutely free for children up to the age of 16. And people older than age 16. Conditions like pregnant women, people who are having long-term conditions or disabilities, and they require repeat prescriptions or prescriptions which last for about 12 months. In those cases, they are considered absolutely free for those patients. Now, in certain cases, what happens is if patients need repeat prescription for a period of 3 months or 12 months, then there's a fixed charge which they can pay, and these can be made available to them at a set specific cost. I think it's about £29 for up to 3 months, and if you need repeat prescription for a period of 12 months, then it will be about £104.
Does disability living allowance give you free prescriptions?
I think it will, because the definition of the safety net actually covers people with long-term conditions or disability in some shape or form. There is a list which clearly categorizes the different forms of disability, and that is where the means tested they kind of test and classify that this as a disability because it does not allow the individual to do their normal daily function, without any supervision. And
I was just wondering, because I had a friend who had celiac disease, and although because they had to buy a lot of wheat-free food, I think celiac disease gets an exemption, doesn't it? I think prescription exemption fees. I don't know.
It could be. I think keeping in mind this is more of, I think, if my knowledge serves me right, it's primarily related to some sort of allergy to gluten in particular, and I think then there's this is basically to do with the immune system. Yes, if it is something, this is something which I'll have to look into in detail, but I think if it has been identified as something which is a concern in terms of causing, or creating a disability in the long run for the individual, then it is classed as a disability. And in those cases, the individual will actually fall within the safety net of having the prescriptions and, all these things given to him or her, free of cost. So, again, specific, but I think it should be covered. It should be covered from looking at initial, information that I could glean. It probably looks like that it will. Coming to the next aspect in terms of, how the healthcare system financed. I think this is a pertinent topic that we need to understand when we look at healthcare provisioning. So how much of it is in terms of GDP, which is spent, where does the funding come from, how does the NHS bridge the deficit? These are things that we want to be able to understand, and I think this is a key problem which the current government is actually grappling with. As we are living longer, there are new diseases, new illnesses being diagnosed. Cure for some of these are not available at this moment, so it requires planning, and obviously it requires, the expenses on the NHS side are increasing, and because of which it is one of the toughest challenges which the government has, is to keep the NHS properly funded and properly financed so that it is able to offer the key services for which it's been set up post the World War II era, that it is able to continuously provide these services and also improve patient care while meeting the needs of the patients. So I think in 2012 the figure was about 9.3% of the GDP of the UK in terms of the spending. I think it was about roughly 200 billion which was being spent on the NHS, 1/6 of the overall budget being spent on the National Health Service, and this accounted for about 84% of the total budget required by NHS to run its operations. Now, the major fundings actually come from general taxation, and a small portion of that comes from the national insurance contributions. In 2006-7, if we correlate to that, this is the fifth phase, or the phase in which there were large-scale changes in the NHS. At that point in time, up to 76% of the budget for NHS actually came from general taxation, and up to 18% of that came from national insurance. Now, in the current funding system, NHS gets a lot of funding from different trusts. It gets funding from general taxation, national insurance contribution, and also one-off fundings which are given or sanctioned under various broad heads. Like, for example, the NHS funding might be slightly different from the funding which is given to the mental and social healthcare services. Today, there's a provision to create funding for the IT infrastructure, which is being, employed within the NHS. So there are some other pockets through which NHS can actually derive funding, and this funding, comes in from different channels. But majority of it is primarily through the, the general taxation and small contributions which come in from smaller proportion of contributions which come in from the national insurance contributions in terms of tax. What also happening is government is also currently promoting in private sector, in particular, the use of insurance policies. So some of the illnesses which are still not funded within the NHS, or drugs for these illnesses are not funded within the NHS, a lot of individuals then fall back onto privately financed healthcare, and if they are able to afford for it, they basically take that route. And most private expenditure which is happening is primarily, the biggest set which is taking place is actually on the over-the-counter drugs and, other medical products or treatments which are largely related to things like, surgery, cosmetic surgery, things like that, which people are, which they are free to take, and obviously are able to take through their own private means. Either the coverage is through paying for it privately, or the coverage is through taking out a private medical insurance in some cases, for certain types of treatments. The key point here that I would like to kind of put out is that a lot of companies in particular have already, companies like, when we look at large organizations, even in public sector organizations, what is currently happening is that these organizations, when there is private-public partnership, they have gone on to providing certain things like the dental insurance or dental treatment, which is covered through the company, privately for the set of individuals which are employed within the company, and it is given off as a one-off perk, or as a kind of a add-on incentive for working within the organization. So because there's a coverage coming in through the private sector as well, even if it's for dental, treatments and insurance which is provided, that is where we kind of have to look at that there is privately financed healthcare as well, even if it is for, dentist-related treatments or dental-related treatments which are being spent for by the company on the employee. So you get dental-free insurance once a year, which you can claim against, and you can, it's capped at certain amount, which basically falls within the privately financed healthcare, if that makes sense.
Yeah.
Okay. Now, going to understand in terms of, how is this delivered primarily. Let's look at how is the system working and how are these services being delivered to the general public. So what we do see is that the primary care, is primarily delivered through the GP surgeries in particular, and they are called as the gatekeepers for secondary care. So in 2013, there were about 40,000, general GP surgeries, in which 40,000 GPs, and the services were being given across through about 8,000 GP surgeries or practices. Now, each GP surgery had an average of about 7,000 patients registered, and that meant that if was a GP surgery which was set up in partnership, and there were 5 or 6 GPs looking after that GP surgery, running that surgery. On an average, there were about 1,500 patients per GP. Recently, we've been reading, obviously, in the news is that Jeremy Hunt was trying to kind of promote that the GP surgeries now should be open 7 days a week. I think, and that has gone into a bit of a deadlock. That's not been agreed, and I think he's probably scaled that back, or I haven't heard about it for a while in the news, at least from my information. But there was a case that he was trying to make that GP surgeries should be open 7 days a week. And this particular primary care should be provided and accessible to the patients from their surgeries, rather than Monday to Friday. It should be, 7 days a week. Now, in tandem to that, what we do see is the secondary, care is predominantly provided through specialists and specialist doctors, which are within the, the remit of health and social care. And there are about 41,000 consultants, to the best of my knowledge, when I compiled it, and about 54,000 hospital doctors, which are in training, which kind of meet this particular requirement of secondary care, which is provided through the hospitals and the PCTs and the CCGs, the 211 CCGs, which are set up in England in particular. And there are some private practices which are also currently running, and there are about, to the last count, I think in 2014, the data from the NHS website was about 1,400 private practices which were running, and some of these, have they provide just not just the general, care, but they also provide services which are enhanced services, things like when people go in for, private care related to things like cosmetic surgery and other treatments, other forms of treatments which they want to take. And in those cases, if we combine all of them together, I think there are, in terms of about 3,500 such practices within England, in particular, as per the data of 2014. Is that okay?
Yeah. Now,
GP practice, this is something which is known. I think it's the normal first protocol. If I have an illness or if I fall ill, my kid is not well, they're down with cold and cough. The first call of protocol is to obviously go into the GP surgery. I think in 2009-10, a lot of GP surgeries started to offer something called the walk-in surgeries or walk-in centers. That means you do not need to take an appointment as long as you're coming between the 8 o'clock to, I think, 10:30 in the morning hours. You are able to walk in and see a GP, one such, one appointment, one per patient, one such problem you could discuss with your GP without having to take appointment or do registrations. Now, I think this has also undergone change very recently. I think from some of my colleagues who are doctors, I did find out that locums are no longer being promoted within the NHS. I don't know whether that's affected you, but what I heard very briefly last week was that the NHS, in some cases, is looking at closing down locums altogether, and they're going to be trying to offer these doctors who do locums permanent jobs within the NHS, take them on roll essentially. Is that correct?
Could you just say that again? I was just reading the slide.
Right. Okay. I think one of my friends did tell me that he used to do a bit of locum, but locums are now being stopped within the NHS. So doctors which used to do locums or were consultants doing some additional locums in different hospitals have now been asked to come on roll if there is a shortage or a requirement, and they identify that this can be filled in by taking somebody on a full-time basis. Then the NHS is looking at taking those doctors on rolls as against promoting the concept of locums.
Yes, I'm sure it's true. I read something when this legislation had recently come out, and it said that although the government had passed legislation or some form of rules or guidance, that although they had tried to reduce the number of locums had grown since it was passed. So, yeah. Although ironically that they were going in the wrong direction against the guidance, but I think that was in the very first onset due to external factors, and probably now the guidance bitten in and it probably is coming down.
Right. Okay. And I think that's the point which is basically put out, was that about 66% of GPs are private contractors, and approximately 60% of those they practice under the nationally negotiated GMA contracts, service contracts, and that is where the NHS is now trying to, I think, save about £100 million by reducing locums with doctors in particular in certain CCTs wherein they have been using this practice, I don't know whether it's right to say, but or clearly exploiting this practice of doing or giving locums to doctors. So there's a major drive to, I think, save about £100 million in terms of costs, looking at this particular step, which I think the NHS Trust or the board is now looking at taking. But I think so. That's a different discussion altogether. But I think from our point of view, what we want to be able to understand is that, okay, what's the in terms of this provisioning of healthcare, how it is delivered? It's delivered to GP surgeries, the primary care, the secondary care is done through the hospitals, and obviously the number of doctors and nurses working within these places is able to then obviously provide this care to the patients. Looking at something which is which is called the outpatient specialist care. This is something which basically requires payments to be done for consultations if patients do require, and in some cases this is done through the hospitals or further referrals or further referrals given by the hospitals to the patients to be able to choose a hospital to visit and then take a consultation. Now, can you think of an example wherein an outpatient specialist care would be recommended by NHS? It is funded through NHS, but the patient would have to go elsewhere to look at getting that particular test or the result or the care done.
I'm sorry, I'm not with you. Say it again. Can I think of an example of a
outpatient specialist care? That means where the patient has the option to get a treatment done outside the NHS, but the NHS pays for that treatment.
Probably hip operations.
That's correct. And I think in the news, if I remember, breast implants, the PIP, which is, I think, last year, they came about that, they were faulty and stuff like that. So about 40,000 women, and there's a waiting list. So the government did say that some of them could go out and, obviously get these done or removed privately, wherein the NHS will still pay for the, the specialist care required, to get these removed. So hip replacement, yes. Hip and knee replacement is another example. The breast implants, which happened, the faulty implants, which were done by the French company, I think, and it got highlighted last year, were covered under the outpatient specialist care. So sometimes these things, and sometimes what I do see is that some treatments and some part of these are covered through the cost, wherein the NHS primarily might not have, the facilities and also the, the expertise to be able to carry these out on a basis wherein it has to be done in a particular time frame, and in those cases, sorry, excuse me, in those cases, it looks at, kind of authorizing outpatient specialist care, which is where the patients are able to go out and get that treatment done. The NHS still actually funds those services. Coming across very briefly to, the hospitals, looking at that, I think some of these, when we look at primary care and then we look at secondary care, it's obviously covered under the hospitals. GP surgeries do refer patients to hospitals, which is to look at the secondary care when or treatments which cannot be done at the surgery. Some of these hospitals are owned, and obviously they are owned under the NHS Trust. They are directly accountable to the Department of Health. There are currently about 102 such hospitals, although the government is trying to, ask them to form and become a trust so that they can be better regulated and obviously better funded. Currently, about 147 of them are regulated by Monitor, which is another body a body which looks after, an economic regulation within the NHS, and it works and kind of directly supports the operations in NHS, but in terms of its reporting and its responsibilities comes under the Department of Health in general. So the foundation trusts, obviously, they say enjoy greater freedom from the central control of the CCGs, and it's easier for them to access funding in certain cases, or excess funds if they're running in deficit. Essentially, I think in the new policy and the way the NHS is going forward, the government wants all hospitals, including the mental health and ambulance services, to become a foundation trust in the near future, wherein they will have easier access to funds, both in the case of surpluses or deficits, which can be drawn out from the Department of Health, and also under the monitoring, under the agency which is Monitor, which looks after the licensing and economic regulations for NHS.
That's all pretty clear. Can I just take a small back step?
Yeah.
Because the only thing that was going through my mind was about the previous slide 10 was CCGs providing outpatient appointments on nationally determined rates.
Yeah.
I just wondered, does that mean that every general practice now has to have a practice-based commissioner? Is it compulsory now?
I might not have the answer for that, to be honest. I'll have to look into that, to be honest.
It's only when I left the situation that there were a few general practice managers employing alongside them a part-time practice-based commissioner, purely to deal with what I thought was that aspect of the GP management system, but there were government incentives to bring in a practice-based commissioner, but I'm not sure where that is, and I'd be grateful to know.
Right, that's fine. I'll look into that. I've written it down here. So the question that we are looking at is, I know a lot of GP surgeries were asked to introduce something called a practice manager, which is that what you're referring to?
No, I think most unless it's single-handed practice, a single GP like on an island in Scotland, most of them, when there's 2 or 3 and hopefully 4 GPs, have a practice manager. But in the big practices, the practice manager also needs a part-time practice-based commissioner, not to look at the funding of the GPs and the district nurses and the running of the GMS contract, but also to have a practice-based commissioner purely looking at the funds for the patients in the hospital.
Sure.
On the national tariff system. That was what I was understanding, but I don't know where it's gone. I'm about 5 years behind in what I say. So.
All right, that's absolutely fine. I'll come back to you on that. I think this was primarily, after the maybe this was something which was introduced in 2009, where they clearly said that yes, GP surgeries which have operating budgets in excess of 1.5 million were supposed to bring in this commissioner, which was to look at the costs and the provisions, and look at the IT and a couple of other things with regards to patient care and the patient record management. I'll come back to you on that. I think I've got the idea. I'll come back to you on that.
Yep, thanks.
Okay, good stuff. I think the next slide which we were looking at was, there are about figures-wise 548 private hospitals which range between 500 to 600 clinics in the UK, and they are able to offer a full range of services, including treatments which are either unavailable in the NHS or are subject to long-term waiting times. Things like cosmetic, bariatric surgery, fertility treatment would be a large chunk of these private hospitals and clinics coming under that figure. And then you also look at, in some cases, public funds have always been used to purchase some private hospital care, such as for mental health care patients, when they are, when they receive the primary care within the NHS and they require long-term, care, or say, for example, in the case of when we look at, when we look at in the case of our military servicemen. Now, some of them who've returned from Iraq, have returned from Afghanistan. What they have been, they have been treated and obviously have received treatment within the NHS, but will require long-term care, which is from an aspect of mental health care. Then in those cases, the public funds are also used to kind of purchase, private hospital care for such patients when they require long-term treatment, to bring them, kind of in the main line, or bring them back into the main line, in terms of society. So that's something which I understand. Sometimes public funds are also used to kind of purchase long-term, long-term caring for patients which have suffered, and that is done with partnership, wherein the funding is provided to NHS, but obviously their treatment would take place in a private care or private hospital. Just going through some of the other slides that we will look at is, now we've talked about the national health services in particular. One of the key things which is now coming up is social care services and mental health services. And you gave me an example of, one of your friends earlier starting with, but one or two slides that I have here, for mental health care and long-term care and social support services which are required. Now, mental care obviously is an integral part of the NHS after 2009, and it includes a lot of, services, including drugs, prescription drugs, which are all covered under the, the NHS treatment, in particular for any patient suffering from mental health care illnesses. Now, less serious illnesses, including chronic conditions such as, depression, anxiety disorders, are usually dealt by GP surgeries. But those which require long-term, care, for example, cases wherein you have migraine, for example, or patients which are diagnosed with having chronic conditions within these disorders, are then referred to the mental health care services, wherein the patients are then let's put it this way, cared for using a model which is community-based, or private-public partnerships which are done with NHS to kind of support these patients and support their treatments for these patients. And that is where I will kind of leave this, because I do not have much detail on this area, but this is one of the aspects that we need to look at very briefly. If you look at the, what do you call the indicative content under this particular unit. This could be something that we could study in a bit more detail, but it's just one of the contexts that we need to understand, that within this care, mental health care services and what do you call long-term care and social support is now included within the NHS, and this is something that is how it works as far as it is looked at for NHS in England. The other thing which I would kind of just briefly go through for today would be the fact that when I look at funding, for example, when we look at provisioning for mental health care, a quarter of the NHS fund, which is currently, when we look at figures from 2015-16, is actually being used to kind of take care of and provide mental health care services and long-term care, for people which have disabilities or illnesses which have been diagnosed as illnesses which require long-term care. And this then is provided through a combination of something called the inpatient care treatment through the hospital trusts, and also to a certain extent support given by GP surgeries in certain cases. And it could lead to, for example, therapy treatments, which would also primarily improve the illness at the patient's end. So they are all considered under the review of mental health care, long-term care, and social support, which the NHS is now supposed to finance and also offer in terms of both needs which require medical and also skill-based nursing, in particular skill-based, nursing needs, which are again a bit of a there's a bit of a gap in terms of the required nurses within the NHS, but these services are predominantly offered after the treatment is done or offered by the NHS or by the doctors. It's predominantly the post-treatment care which is taken care of by nursing needs. So it could be, workers, social care workers or healthcare workers, which are then required to go to the patient's home to be able to deliver, medication, to look at monitoring the improvements in terms of health and other things, which all falls within the remit of the NHS now. And if I just go forward on this, what I've done is, this is something that we've discussed, but if you see, this is obviously the organization of the healthcare system in England, which I've put forth, from the website, which basically describes how the structure of the, NHS now works within England. And this was directly related to the question that was probably put, and we discussed, I think, a few weeks back. And the subsequent slides are basically defining, this particular structure, how this works, which I think is pretty much, a bit of reading that you need to do just to understand each of the individual bodies, CQC, Quality Care Commission, the monitor, the NICE, and how and what their roles are when we look at, this particular structure working in terms of providing health to patients in England. And in the last, I think I've looked at how NHS is looking at maintaining, which they can try and contain, because obviously NHS is one of the largest beneficiaries of the, national budget, and this budget is expanded £1 billion as per estimates last year, which is what the NHS gets from contributions and some of the other funds like the King's Fund, the Commonwealth Fund, wherein the funding also comes in from the European Union to provide and fund for some of these services offered by NHS within England and in general within the UK. I think as per news, there was a projected gap of 20 billion, which was being discussed, in the news articles a couple of months back, and this was required to basically kind of bridge, the gap in funding or the deficit, which is kind of creating a gap in terms of providing these services to patients, when it is leading to longer queues, waiting times, some of the drugs not being offered under prescription drugs because of the costs and approvals which have not taken place in general for them to be offered by NHS, in the whole remit. And I think apart from that kind of cover now, in terms of costs, the mention on the locums, there are cost-cutting drives or measures the NHS is looking at in general to be able to reduce costs on ancillary services and prioritize those towards the patient services, in particular the healthcare services which is required. And this is something which I think is a priority as of now with the government. So it's a big challenge, and I don't know in terms of how this will be countered, but it looks like that without increasing the funding, there is no way that the NHS can continue to provide these services or offer some of these services absolutely free of cost going further, considering 3 or 4 factors that we've been discussing again in terms of expectancy, in terms of immigration, in terms of population rise, in terms of new illnesses and diseases being discovered, and obviously Britain coming out of the EU, where part of that funding was coming from the European Union. I think that is where I would stop today, if that makes sense in terms of this particular learning outcome.
Okay, is 25 the last slide?
25 is the last slide.
Right.
That is the last slide, yes.
It is, super. Okay, thanks.
So what I've done is, apart from this, I've sent you one or two handouts.
Yep.
And I'm going to try and come back to you on the question that you asked me on the commissioners front, the practice-based commissioning.
Yes, please.
Which was introduced just to see, how it will kind of, reinvigorate the use of budgeting, use of budgets primarily allocated to the GP surgeries. Any questions, any comments on this, or any you have any queries for today's session?
No, I think that's everything. I will go through those again if it's. I suppose there was the question about Gulshab. What Gulshab had said about LO4 missing from Moodle that I seem to have.
That's fun. What I will do is, so in LO4, we are basically looking at, covering things like the role of public health system and promotions in provision of healthcare services. So there are things that I will put on, which basically would talk about things like, like NHS does a lot of promotional campaigns from time to time. One of the recent ones, or one of the ones which they've been running for the last couple of years, is the one on obesity, weight control, sugar reduction, things like that. So there are a lot of promotional campaigns which NHS actually runs both in the national, I would say in the national context as of now, which is looking at preventive care, and that is what the LO4 will essentially cover. So we are looking at studying the role of healthcare promotion or health promotions in general, which are a direct let's put it this way, which have a direct impact on how some of the policies are shaped up within the NHS from a long-term perspective, and also how some of these promotional campaigns kind of hit on the national and international socio-political issues, which are things like I can recall the cancer campaign, for example, the smoking campaign, which the NHS runs from time to time, the diabetes, heart attack campaign, which it does run on television and, other places, wherein through GP surgery, there is education which happens on certain things like the STD, sexually transmitted diseases. Those kind of campaigns which the NHS runs are basically going to be the remit of study of Learning Outcome 4. Wherein the idea is to understand what is the role of these health promotion campaigns in particular, how these campaigns affect the formation of public policy or shapes of the policy within the NHS, and last but not the least, we'll look at the studying the success and looking at basically whether these campaigns are possible, successful, how they are made possible, and where does the funding of those campaigns actually come from. So that is basically the understanding that we have to do for LO4, and I'll upload one or two presentations that we have which will cover that learning outcome to give you some idea, and I'll drop you an email once I've done that.
All right, thanks very much. Thanks a lot.
Okay, take care, Dr. Matthews. I'll speak to you then soon, and I'll send this information across with regards to the practice-based commissioning to you, hopefully by tomorrow.
Thanks. I'll go and have a cup of tea now. Thanks.
Yeah, me too. Thanks.
Bye.
Take care. Bye.